No, okay. I might just have to go on my PC. Yeah, I'm not just being funky. Alright, you said it was endocrine?
Yeah, endocrine diagnostics.
Endocrine diagnostics. Alright, Graves. Alright, let's do this. So you got a timer?
Not yet. I'll just Google timer. Alright. Let me know when you're ready.
Okay. Yeah, start the timer now. I'll start reading.
Yeah.
Okay, I'm ready. Questions?
Yep. So, what is your diagnosis?
Given the symptoms of hypothyroidism and low TSH, I am concerned about the main cause of hyperthyroidism, and this could include Graves' disease, and I'd also like to exclude other causes of hyperthyroidism, such as the acute phase of Hashimoto's thyroiditis, potentially other subacute thyroiditis diseases, including de Quervain's thyroiditis. I'm concerned about thyroid nodules, and I'd like to also exclude malignant causes of hypothyroidism, which could include thyroid cancer, and this could be follicular, anaplastic, medullary, etc.
Awesome. What investigation would you perform?
The diagnostic investigation to identify the etiology of hypothyroidism would be a histopathological analysis of a biopsied specimen, and this could be done via a fine needle aspirate, for example. However, I might like to begin with bedside, laboratory, and imaging first. So bedside investigations, since this is a female, I might like to order a pregnancy test just to exclude whether the patient is pregnant, as this can affect the management of thyroidism. I would like to then do full blood count, looking for any evidence of just for baseline function. EUCs, looking for evidence of electrolyte derangement that could be present, and I'd like to get thyroid function tests, which have also already been done, but potentially reference that. And I could also proceed to then do imaging. So I might like to do an ultrasound of the thyroid to look at the general architecture and any presence of nodules or cystic lesions or congenital malformations, and then I could proceed to either a CT if findings are equivocal, or then a biopsy.
Okay. What are some things that can affect thyroid function?
What are some things that can affect thyroid hormone or thyroid function?
Thyroid hormone.
What are some things that can affect thyroid hormone? So, a thyroid stimulating hormone from the anterior pituitary can increase levels of thyroid hormone, and the same for thyrotropin releasing hormone released from the hypothalamus. Those would be the main two causes of an increase in thyroid hormone. I believe other hormones of the anterior pituitary can also, through negative feedback, decrease thyroid hormone production.
Okay.
Possibly growth hormone? I'm not sure.
So, next question. How would hypothyroidism explain the patient's symptoms? Actually, why don't you tell me what are possible symptoms of hypothyroidism?
Yeah. So hypothyroidism results from increased levels of T3 and T4, so that's triiodothyronine and thyroxine. And these bind to nuclear receptors and upregulate genes such as the sodium-potassium ATPase pump, and this can cause increased heat production in the body, and so the patient might feel warm. They may also have an increased activity of the sympathetic nervous system due to upregulation of beta receptors, and this may present cardiovascularly with tachycardia due to activation of beta-1 receptors. Activation of beta-2 receptors can cause vasodilation, and the patient might present with flushing. We may also observe diaphoresis due to increased temperature, and there may also be a fine tremor at the hands. Other causes of hyperthyroidism potentially associated with specific conditions like Graves' disease could be the deposition of immune complexes, and that can cause conditions such as pretibial myxedema, and exophthalmos could be another sign of hyperthyroidism.
Yep, that's very good. Now let's keep going. And this is an interesting question. So how does hypothyroidism cause hypertension and tachycardia apart from the sympathetic overactivation? Very niche type of question.
Well, sympathetic activation of beta-1 and beta-1 and alpha receptors and the release of catecholamines results in tachycardia. Could this also be a hypertension? Could this be also due to I'm not sure. I can consider maybe renin-angiotensin-aldosterone system, but that's also activated through the sympathetics, and that can cause vasoconstriction due to aldosterone release. I'm not sure.
That's right. That was very good though. They're like on the right path. Last two questions. So, what's a thyroid storm? How would you define that?
A thyroid storm is an acute medical emergency characterized by a significant increase in T3, T4, causing an exacerbation of hypothyroidism symptoms. It can potentially predispose the patient to life-threatening complications such as arrhythmias and warrants urgent management.
Yeah, very nice. And how do you treat hypothyroidism?
The treatment of hypothyroidism may depend on the condition. So in the event of a malignancy, for example, surgical resection may be an appropriate management alongside potentially chemotherapy or radiotherapy. In conditions such as Graves' disease, we may there's medical management with I'm not sure what their medications are.
That's right, but I can see you sort of have it's in your brain. I can see you have the structure. Why don't you tell me what the pathophys of Graves' disease is?
Yeah. Graves' disease is caused by the production of autoantibodies, and these autoantibodies will bind to your TSH receptors. And as a result, we get the release of T3 and T4. And through negative feedback, that's also going to decrease our levels of free thyroid stimulating hormone.
Very good. And that sort of explains the questions then. That's good. And that wraps up the 8 minutes. We just go through some feedback now, yeah?
Yeah, I had no clue.
It was decent, like considering that you haven't done this case. Like,
yeah.
I can't really remember stuff from phase 1.
I made all that up from third year. But let's do it.
The main thing I would say is like from the beginning, like the diagnosis, right? With thyroid cancers, generally speaking, the patients are euthyroid.
Yeah.
Yeah.
True.
So, like now that you know that, you probably wouldn't mention the
malignancy.
Biopsy.
Yeah. So you wouldn't do biopsy in this case?
No, you wouldn't.
Okay.
So, do you know what the 4 main causes of hypothyroidism are? So, Graves' disease is one.
hyper. Okay. The main causes of hyperthyroidism would be Graves' disease,
Mm.
thyroiditis, like subacute thyroiditis, so
Mm.
decoy
Yeah.
veins, etc. What's the other type of thyroiditis? Subacute
You
thyroiditis?
get, yes, I think subacute is. I mean, you can get postpartum thyroiditis, but that's not what you're talking. There's like Hashimoto's, right?
Acute
Like
phase of Hashimoto's.
Hashimoto's. Yeah,
And
you
then
said that.
could you also get toxic multinodular goiter?
Yeah, very good. Yeah.
And what else?
One more. It's just like a thyroid adenoma.
Ah, so
Like,
benign tumor,
like a
right?
single. Yeah, benign.
Okay,
So the benign ones can
yeah.
actually make hormones, but the
Mm.
malignant ones not really.
Okay, so to reiterate, the causes of hyperthyroidism, you'd consider Graves' disease as your number one cause, and then you're also concerned about the acute phase of Hashimoto's thyroiditis. You'd like to exclude subacute causes of hyperthyroidism, including decoy veins. And what was the other type of subacute thyroiditis?
I'm gonna look it up. So
Subacute thyroiditis.
subacute is decoy vein.
Oh, right. So there's no.
Yeah. Isn't it? Or are you thinking of something else?
Is it?
Like subacute granulomatous decoy vein thyroiditis. That's like the entire name. Unless you're thinking of something else.
I think there's a painless subacute thyroiditis.
Oh, yeah, you're right. Which one is that? I think.
Oh, it's
that's
just
like
postpartum. It's just referred to as postpartum.
Is it?
It's autoimmune thyroiditis. It can occur in about 10% of pregnancies. Yeah, I think you're right. And then recovery.
There's also this thing called Rydell's thyroiditis.
Is that what we're talking about? Rydell's?
Yeah, that's the rock-like painless goiter that you can get.
Rydell fibrosing thyroiditis. There's inflammation of fibrosis. And does that classically presents as hypothyroidism though?
Yeah, that's hypo, yeah.
So that's Rydell's thyroiditis. Okay, so that's a
Rydell's.
hypothyroid cause. All right, let's see what they've got. They said thyrotoxicosis, likely due to Graves. So do you just call this thyrotoxicosis when there is increased T3, T4? How do you know?
Like, the thing is, I searched up what's your understanding of the difference between thyrotoxicosis and hypothyroidism? Like, from what it's kind of confusing, but from what I understand, let me know if this makes sense. Thyrotoxicosis is sort of the clinical manifestation of elevated thyroid hormone.
Oh, right. That makes
from
sense.
any cause.
Mm.
Yeah, but then hyperthyroidism is only when it's
Lab.
thyroid hormones secreted from the thyroid gland. If that makes sense. Because, like, if you look at the table, there's other non-thyroid causes of excess thyroid hormone production.
Yeah, what else causes... So, thyroid can be... non-thyroid. There's extrathyroidal sources. So those can cause those you call them thyrotoxicosis, but it's not a hyperthyroidism per se.
Yeah.
I didn't talk about any of those things. They can be ovarian tumors. They can be drugs such as I completely forgot that. It can be diet. There can be follicular carcinoma. It says can potentially release thyroid hormone.
Yeah.
What are the different types of thyroid malignancies? So we said it was anaplastic, follicular, medullary, and I always forget this one. Anaplastic, follicular, medullary, and colloidal. No.
It starts with P.
Papillary.
Yeah, nice.
Oh, I missed. How did I miss that? So it's follicular, papillary, anaplastic, and medullary. So follicular, papillary, medullary. That kind of makes sense. So papillary, medullary, follicular, anaplastic. Those are the main ones, right? 4?
Yeah.
Okay. Alright.
Yeah.
Okay. And we said the main cause of hypothyroidism were Graves, acute phase of Hashimoto's, toxic multinodular goiter, and then just subacute, right? So decoy veins.
Yeah.
All right, cool. Next question with feedback.
Sweet. So yeah, that was good. With the investigations, like with diagnostic, I think you mentioned TFTs, but then because Graves is the most common cause of hypothyroidism, you can mention the anti-TSH receptor antibodies.
Ah, right.
And you sort of explained that in your reasoning. And then for bedside, you see how you were talking about the tachycardia and the arrhythmias, you can do ECGs.
Right, true. Bedside ECG.
Yeah.
I was thinking about what I would do. Yeah, that makes sense.
And then pretty much everything else you got. The only other thing with the LFTs was interesting, but apparently one of the medications that we give called PTU, propylthiouracil, it can cause deranged LFTs. So that's why. And you said the ultrasound, and there's also this radionucleotide scan, which essentially
Technetium 99, where it can see the radionuclide. When would you consider malignancy then? When there is a lump, right? So you'd only biopsy when there is a lump. This patient didn't have a lump; they just had a hypothyroid picture, so we don't biopsy. That's the logic, right?
I believe so. Yeah.
Yeah. Okay. Cool.
Because I remember they always teach us that the malignancies, or the cancers, are euthyroid. The thyroid cancers are euthyroid.
Yeah. Okay. That makes sense. All right.
Yeah.
Cool.
But I suppose that they might also do they could do radionucleotide scan, and if it's like a cold nodule, then that would mean there's a chance it could be cancer.
Oh, right, because hot nodules are usually infectious or inflammatory, right?
Yeah,
Okay, so interpret the blood results in terms of thyroid hormone physiology. What would be the best answer for that?
This is not even a question, bro. Yeah. Anyway, I wasn't really sure what the question was here, but I think you sort of explained it, to be honest. You said that the TSH is low because of the negative feedback, right? Do you remember? And then if it was a different cause, then TSH might be elevated as well. Like if it was a pituitary adenoma secreting TSH.
But do you understand the whole thyroid physiology? Can you explain the whole follicles and colloid and stuff?
I can try. So, do you want to give it a crack first, or should I just try
I don't remember. I just start making stuff up.
Mate, I just crammed this in the 5 minutes that we allotted to each other. But okay, so basically, the thyroid hormones T3 and T4.
Yep.
They require iodine to be produced, right? And we can get iodine from our diet, which is why, in areas where there's low iodine, people can get cretinism and hypothyroidism, right?
Yep.
And the way it works is the iodine gets transported through the follicular cells.
Yep.
Along with sodium. So there's some sort of transporter that transports both in sodium and iodine.
Right.
Yeah.
Do we have to remember the names of these channels?
I don't know. It just says active transport of iodide.
I remember PEMC and there's names, but all right, yeah, keep going. I'll try.
Yeah, and then there's also a protein that's produced in the follicular cells known as thyroglobulin.
Yep, I remember that, and it's secreted to the colloid, right? Is it secreted into the colloid?
Yeah, it's secreted into the colloid, and then the thyroglobulin has amino acids, and the particular amino acid that it has is tyrosine.
Yep.
Yeah, so tyrosine plus the iodine, that if you have one iodine, then it produces MIT.
Monoiodotyrosine.
Tyrosine, yeah.
Tyrosine, yeah.
Monoiodotyrosine, and then if there's two iodines plus the tyrosine, then it's diiodotyrosine.
Yeah.
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 And so, then there's the thyroid peroxidase, which is a really important hormone for T3 and T4 synthesis.
Yeah.
And it does three main things.
Yeah.
The first thing it does is oxidation.
Yeah.
Which is you get essentially you produce I2.
Yeah. Is I2 the diiodotyrosine?
No, it's sort of, I think it combines two I minuses, and then it produces I2. And then that I2 can then bind with the tyrosine, and that can produce DIT or MIT. Yeah.
I'm a bit confused. So, okay, let me just recap. You said the iodine is ingested. It gets brought in through sodium co-transporter into the follicular cell, and then the pendrin says here the pendrin channel enables iodide. So when does it convert from iodine into iodide? Is it a
I think from my understanding, it's before it combined with the tyrosine. It's sort of, and then because that's the first step, it gets oxidized. Then there's like organification where it actually combined with the tyrosine, and then it gets coupled. That's when the DIT and the MIT combine to form T3, or the two DITs combine to form T4.
Yeah, and then lysosome enzymes can cleave T3 and T4. So what does TSH do in all of this?
I think it increases the activity of the sodium and sodium iodine channel, and it probably also increases the production of thyroglobulin.
Oh, you know what? It makes sense now. All right, so I can see that what's happening is we ingest iodide, not iodine. We ingest the iodide, and then we mentioned it gets brought into the follicular cells through the sodium iodide co-transporter. That's active transport, and then right there, it gets oxidized in the follicular cells into iodine. So that's its neutral I2 now. Then the iodine is conjugated with, it binds to tyrosine residues on thyroglobulin, and then we can link iodinated tyrosine residues to form triiodothyronine and thyroxine. And then lysosomal enzymes will cleave the T3 and T4 off thyroglobulin. So thyroglobulin is kind of like the manufacturer. What does thyroid peroxidase do then?
That's the thing that causes oxidation.
Yeah, that makes sense. That makes sense. Oh my god.
Yeah, those are the three things.
If only I'd not crammed this. I remember like studying this and memorizing it, but not. All right. Next question.
So the next question was, this was super niche. What are some things that can affect thyroid hormone? And so what they have is cold stimulates TRH release, estrogen also stimulates TSH release, and then it talks about dopamine and somatostatin. I'm not gonna lie, I don't understand that point.
Somatostatin is the inhibitor of growth hormone. It's growth hormone inhibiting hormone. Is it? Yeah. Okay. So then why would it? What does it do? Dopamine and somatostatin have a negative feedback on TSH. So I guess it's just cross negative feedback. So growth hormone is released by the growth hormone releasing hormone is from the hypothalamus. It acts on the pituitary, which releases growth hormone. And I guess TSH is like a somatostatin will inhibit the growth hormone at the anterior pituitary, but also the TSH at the anterior pituitary. So it's like a cross negative feedback. That's what I'm seeing. Does that make sense?
Say that again.
Basically, you know how growth hormone is being released from the anterior pituitary? And the hormone somatostatin is also known as growth hormone inhibiting hormone. So that would be released to inhibit growth hormone at the anterior pituitary. Okay. While it's doing that, it can also cross-react and also inhibit TSH from the anterior pituitary. So that's, I think, what they're saying. Well, I guess we still have to memorize that, but it kind of makes sense from the level of control. Yeah. It's controlling at the level of the anterior pituitary. So somatostatin and dopamine, I guess I have to remember that. Estrogen stimulates TSH, and then I don't know what they're saying about iodine, but all right, cool.
I guess that's just like, of course, if you have iodine deficiency, then you're not going to be producing that much iodine.
Yeah. Cool.
Easy. And then the next question was just about the symptoms of hypothyroidism. I think you got the main ones.
What did I miss? Is it exophthalmos or is that in hypothyroidism?
Yeah. So basically, the exophthalmos and the pretibial myxedema, those are things which are specific to Graves' disease.
Yeah.
Yeah.
So exophthalmos. So exophthalmos is it only specific to Graves?
From my understanding, yeah.
Okay.
Have you noticed it in other things as well?
No, I don't know.
Because and then I think you mentioned that there's immune complex deposition, But I think like from my reading it's basically fibroblasts.
Yeah.
Fibroblasts have TSH receptors,
Mm.
and so because we have antibodies
Mm.
against TSH receptors,
Mm.
in Graves' disease,
Mm.
those TSH receptors get activated, and so you get deposition of glycosaminoglycans in front of the tibia, right? So you
Yep.
get that pretibial myxedema,
Yeah.
makes it feel like dough, and
Yeah.
also behind the orbit or behind the eye, and that's where you get exophthalmos.
Oh, that
So
makes
it's not really
so
immune
much more
complex,
sense. Yeah, you're
but
right.
yeah,
I was
fibroblast
just pulling it out of my backside, but it makes sense. So it's fibroblasts have TSH receptors, and TSH antibodies can activate these TSH receptors alongside thyroid TSH receptors, and this can result in the deposition of connective tissue extracellular matrix, so compounds such as glycosaminoglycans behind the orbit causing exophthalmos, and in front of the shin causing the pretibial myxedema. Okay, that makes sense.
Yeah, easy. Good. I think that's pretty good.
Anything else from that case? Is that all the questions?
Oh
yeah, how does hypothyroidism cause... Yep.
It's basically, the formula blood pressure is equal to cardiac output times TPR.
Yeah.
Yeah. So apparently, thyroid stimulating hormone can increase, and also T3 and T4, they can increase the myosin filaments in the heart muscles, and so it increases contractility.
So this is outside
so
of sympathetic control, yeah. So that will increase blood pressure.
Yeah.
Why do you get a tachycardia?
Sorry?
Why do you get a tachycardia? It says, why do you... Because the blood pressure, I was like trying to think of things, but tachycardia made no sense.
Yeah. Even in the notes, it doesn't really explain the tachycardia. I guess the tachycardia could be sort of a reflex tachycardia, because the other thing it says is that T3 and T4 acts in the peripheral tissues causing vasodilation. And so that, although that decreases the TPR, it activates the RAS, like you said. And so if you activate the RAS, you get increased blood volume. And then if you increase the preload, you can increase it. You sort of get stretching of the heart muscles.
That wouldn't cause tachycardia. That just cause like a increased cardiac output,
increased
right?
Preload. Yeah.
I don't know. But yeah, no, yeah.
I don't know.
Let's see.
I don't know about the tachycardia, but the hypertension sort of makes sense.
Yeah. So the notes just say increased myosin filaments, right? Contractility, stroke volume, beta-1 adrenergic receptors, RAS system. Oh, here it says it also increases chronotropy as well. So yeah, that would cause a tachycardia.
Yeah.
Alright, I guess that makes sense, sure. So it acts on peripheral vessels to cause vasodilation. It also increases myosin filaments. So it acts on peripheral vessels to cause vasodilation, and the RAS will counteract to cause tachycardia. And then we'll also have... okay, that makes sense. It's a pretty hard question, man. What about thyroid storm? What was the definition of that?
Yeah, so you pretty much nailed it. The only other thing, so like you said, it's a medical emergency. It's acute, it's life-threatening. But apparently it doesn't necessarily correlate with increased T3 or T4. It can happen with normal T3, T4 levels. And so the etiology is unclear. It's just there might be patients might be more responsive to T3 and T4.
Then if they have normal T3, T4, how do you know they're in a thyroid storm? Is it that you'd see the clinical symptoms of hypothyroidism?
Like thyrotoxicosis, yeah.
But then how do you know it's a thyroid storm and not just thyrotoxicosis?
I think it's if you have underlying hypothyroidism that isn't treated properly, and then there's some sort of stressor like infection, surgery, something like that, or trauma, that's when you are more likely to get thyroid storm.
Yeah, here it says they're hemodynamically unstable. So I guess that could be like your little marker. So they have a thyroid disease and hypothyroidism, and you can see they're febrile or hypotensive, or they have neoarrhythmias. That can all indicate that there is thyrotoxicosis. Alright, so the etiology is unclear. It can be related to increased T3, T4, or even normal. And there's usually some stressor. It can be hypovolemic shock. There can be coma. Okay, that all makes sense. Yep, vomiting, diarrhea. Alright, the treatment. How does it all work?
Yeah, so like I saw you were getting to the structure, medical and surgical, right? So the two main medications, or like the main class of
Local
medications, is
thyroid.
the thionamides. Yeah, you remember those, like the PTU and the.
Yeah, I remember
So,
PTU,
so basically,
propylthiouracil. Yeah.
yeah, basically it inhibits thyroid peroxidase, and we sort of talked about thyroid peroxidase. It does most of the main processes in the production of T3 and T4. So if you inhibit it, you're going to get decreased production of T3 and T4, right? But I think with PTU, it also inhibits the peripheral conversion of T4 to T3. So that's like the additional thing of PTU.
It prevents the peripheral conversion of T3 to T4?
No, T4 to T3.
T4. So T3 is the active form, right? And T4 is like the main circulating form?
They're both active, it's just T3 is more potent.
T3 is more potent.
Yeah.
So it also decreases activation of peripheral T3, right?
Yeah. In addition to the thyroid peroxidase inhibition.
Thionamides. Thionamides. They inhibit thyroid peroxidase. Do you remember the side effects?
It was just like a lot of general things like rashes and urticaria. I think it can also cause hepatotoxicity, like especially the PTU,
rash,
right?
Hepatotoxicity.
The LFTs.
Okay, it prevents duodenation. Alright, and anything else that you remember? It's for treatments?
So you can, for surgical treatments, you can, you can take the thyroid out, obviously, but you can also use radionucleotide, like for the technetium 99 labeled iodine. And that just sort of destroys the overactive thyroid. But then I think both of the surgical treatments, they can result in hypothyroidism.
Alright, cool.
Yeah.
That case is done. Oh, that was pretty.
For such a small case,
yeah,
it's pretty packed with information. Like literally, the stem is 2 lines.
Yeah. Let me see if I have any other questions. Iodinated tyrosines linked together. So your DIT and MIT will just bind together to form
T3 and T4.
Oh, so I can see one diiodotyrosine and one monoiodotyrosine form T3, and then 2 monoiodotyrosines form 2 diiodotyrosines form T4. Oh, that makes sense. 2 plus 1 is 3. Yeah, right.
Yeah, nice.
Alright, lit. How did I not make that conclusion in third year? Triiodotyrosine. Wait, alright, cool. Are you ready to go through the pancreatic cancer case?
Oh, yeah.
And then we'll go through the next case you did. Alright. So you tell me when you're ready and we'll go through the...
let's just do it. I haven't done it properly. Where is it? It's a path, right?
Yeah, so you gotta go diagnostics and path.
Alright. Yeah, I'm ready.
Alright. Whenever you're ready. I'll start the timer.
Oh yeah, you can start it.
8 minutes. Oh, my man. Let's see. Alright, so you got the case history in front of you? Okay, so one sec, I'll pop it up as well. Gastro, diagnostics, pancreatic cancer. Sorry, it's under path, yeah. Alright. Alright, so tell me when you're ready, I'll start the timer.
Yeah, go for it.
Timer. Alright, time started now. So when you're ready to answer the first question, let me know.
Go for it.
Alright, so first question, what is your diagnosis?
Yeah, so my provisional diagnosis for this case is pancreatic carcinoma which has metastasized to the liver. And the reason for this is because the patient has a mass in the right and left upper quadrants, and they also have hepatomegaly, in combination with signs of liver failure and signs of pancreatic insufficiency. My differentials for this, I would target the jaundice and separate the causes of jaundice into prehepatic, hepatic, and posthepatic causes. So prehepatic would be anything that results in hemolysis. Hepatic causes of jaundice include anything that causes destruction, like hepatitis, cirrhosis, and the various causes, right, that we sort of mentioned in the other case, as well as other things of the biliary tree, like primary sclerosing cholangitis, primary biliary cirrhosis. And then post-hepatic could be, like in this case, the carcinoma in the head of the pancreas, causing an obstruction. Stones can also cause obstruction, cholangiocarcinoma, and then you can also have extrinsic obstruction.
Yep, and what's one cause of extrinsic obstruction?
Oh, bro, I was just making that up. Extrinsic obstruction. Oh, bro, there's this weird thing called Merizi syndrome. Have you heard of that?
Okay.
Where you have a stone in the gallbladder. Huh?
I've heard of it, but yeah. Anyway, next question. Yeah. What investigations would you perform?
Yeah, so the diagnostic investigation would be a biopsy and then histopathological assessment of that tissue sample. But in the lead up to that, we can do bedside investigation, bloods, and imaging. So at the bedside, we could do urinalysis to ensure that the bilateral angioedema is not caused by a renal cause. For bloods, we would do full blood count, which may show leukocytosis or anemia of chronic disease. EUCs, again, checking for renal function, as well as possibly like hepatorenal syndrome if the patient has renal failure or liver failure. LFTs are, of course, super important. And then we can also do tumor markers for pancreatic cancer, so CEA, CA19.9, I believe. They're not diagnostic, but they can help in monitoring the disease, especially after surgery. And then for imaging, we can do a CT scan, which can help with diagnosis and staging. And then I believe with the biopsy, like you can do percutaneous or endoscopic ultrasound-guided biopsy. But you don't really need to do the biopsy if the CT scan shows that the patient has the cancer, and it's very characteristic.
Yeah. Would an ultrasound be sufficient in identifying a pancreatic mass?
I think if it's endoscopic, possibly, but I'm not sure if,
Okay. And do you always need to do biopsy before surgery? You mentioned that if CT confirms findings, but yeah.
I think if the CT confirms the findings, then you don't need to do the biopsy, and you can just take the mass out and then assess it after the surgery.
Right. Okay. So a CT showed a mass in the pancreatic head with liver masses. Your diagnosis, do you change it or do you stand by the same diagnosis?
Yeah, sort of confirms the diagnosis.
Good. Right. Now you mentioned the two types of biopsies. Which one would you prefer doing on a patient?
I think the endoscopic one is safer in terms of there's less risk of seeding. With the percutaneous one, cancer cells can seed into the peritoneum. I think it's only reserved if the patient has a high stage cancer.
Right.
Or inoperable.
Right. And what is a natural history of this disease?
So pancreatic cancer is one that has, is often manifests late in the disease course. And that's because it has an insidious onset. There's no signs and symptoms. And I think like the 5-year survival after diagnosis is like less than 10%. And then of course the natural history would depend on whether what the stage of the cancer is, the grade and the type, also like patient factors like if they have comorbidities, their age and things like that. But I think that in general, the prognosis of pancreatic cancer is pretty poor.
What are the different histopathological subtypes of pancreatic cancer?
So we can, broadly divide them into exocrine cancers and endocrine cancers. Exocrine cancers, the most common would be your neoplasms of the ductal epithelium, so like ductal adenocarcinomas, and then those make up like 90 to 95% of pancreatic cancers, and the other 5%, 5-10% would be the endocrine causes like the islet cells, so like glucagonomas, insulinomas, VIPomas, all the other omas.
Okay. And are there any other types of exocrine pancreatic cancers that you know of?
Yeah, there are. I think there's like a mucinous type or something. Yeah.
Okay.
I don't know.
Right. And you mentioned that pancreatic cancer is often picked up at the later stages. Could you just clarify what the reasons for that?
I suppose that's because the pancreas has a large sort of reserve, and so you don't really see signs of like pancreatic insufficiency until there's like less than 10% of the pancreas left of functional pancreatic cells. And also it's a retroperitoneal structure, and there's no like sufficient screening programs for pancreatic cancer. Like the CEA and the CA19.9, they're not diagnostic and they can't be used for screening either.
Okay. So you do a biochemical test and you identify that there is high total bilirubin, high conjugated bilirubin, and there is high ALT, GGT, and ALP. The AST is normal. What is your interpretation of these findings?
So these LFTs represent or demonstrate a cholestatic picture, particularly because we have bilirubin that's elevated, and the specific type of bilirubin is conjugated, which means that the hepatocytes have added the glucoguronate to the bilirubin, and then the GGT and alk phos, they also are elevated in diseases that cause cholestasis. The ALT, I think that could be because of maybe spread of cancer to the liver, or like stasis, which is causing damage to the hepatocytes, and there's a bit of necrosis happening.
Very good. Yeah, you're done. How'd you go for time? You just had 30 seconds left. Yeah, that was really good. That was a strong pass. I guess we'll just go through the different the case history and go through the points. I think you nailed that one. That was very good. I guess the only thing is you need to clarify the different subtypes of pancreatic cancer, and also clarify the diagnostic investigations. So you're really good how you broke down jaundice into prehepatic, intrahepatic, and posthepatic. But you have to think about this. You said it could be due to intraluminal and extraluminal causes, right? The pancreas is extraluminal as a posthepatic cause. So when you said you didn't know any posthepatic causes, pancreatic cancer is a posthepatic cause, right? Because the pancreatic head actually receives the common bile duct, and it will combine with the main pancreatic duct to form the main biliary tree that will then open up into the ampulla of Vata. So a pancreatic head cancer can commonly cause an obstructive jaundice. It doesn't have to be due to liver mets straight away, right? It could simply be due to the fact that a pancreatic head cancer causes obstructive jaundice symptoms. Good. Regarding, I don't know what Mirizi's syndrome is. I've heard of it. What is that?
So basically, you have a large gallstone in the gallbladder, particularly in the infundibulum, which is known as Hartmann's pouch, and it's so big that it compresses the common bile duct. You know what I mean? Like, you picture that in your head, like, it's so big, it just compresses the common bile duct, and so bile can't flow. So it's sort of like an extrinsic cause.
So you're saying the stone falls out the gallbladder, moves through the cystic duct.
Oh, it's still in the gallbladder.
Oh,
no, it's still in the gallbladder, bro.
Oh,
yeah,
so it's
that's how big it is, yeah.
Oh, so that's Mirizi's syndrome. Right, that makes sense.
Yeah, if you Google it, there's nice pictures and it just stays in your head.
Look at this guy searching up all these. I love that curiosity. Oh, yes, okay.
Do you see that?
Yeah, it's obstructing the entire biliary tree. Yeah. So the left and right hepatic ducts, cystic duct, common bile duct. Yeah, it's obstructing the entire common bile duct. I might actually copy one of those pictures. It's a really good. Damn. All right, nice. So I'm not going to forget that. Anyway, coming back to pancreatic cancer. You got the urinalysis well. You got all the investigations well. The only thing is an ultrasound, a transabdominal ultrasound is 95% sensitive for pancreatitis. So you could mention that's your... Yeah, so that would be your part of your diagnostic investigation.
So you don't even have to do like endoscopic.
No, you don't have to do endoscopic. If you see a pancreatic mass on a transabdominal ultrasound, and then you see the clinical pictures, then you've got your diagnosis, and then you can proceed to a CT as well if you'd like. And would you want CT with contrast or CT without contrast?
I think with contrast.
Yeah, I don't know. Like, everything is contrast except in kidney stones. That's the one thing I remember. Kidney stones are non-contrast CT.
Yeah.
I don't know. CT, yeah. What about bowel obstruction? Bowel obstruction is X-rays, or the distended bowel gas loops. Do you do a CT for bowel obstruction?
CT for bowel obstruction?
Yeah. Would you?
I suppose you can. I think sometimes you can do like gastrographin and stuff.
Right. Anyway, you
Like
got
you can
the
do enemas. Yeah.
you got the tumor markers right. CA 19.9 is specific to pancreatic cancer, and also carcin embryonic antigen CEA, which you said as well, I believe. Next question. Interpret the results. Yeah. So you mentioned it was post-hepatic. And the reason that ALP is specifically raised is because, as we said, ALP is a specific liver enzyme, right? Whereas AST, which is your aspartate transferase, is kind of non-specific as well. So it can sometimes remain normal. So yeah, you have a cholestatic picture of obstruction, and it's post-hepatic. That's what you got from the biochemical results. Yeah, you got the biopsies perfect as well. You mentioned that you'd only do an FNA in disseminated disease, metastatic disease, because you're concerned about the risk of seeding. And your percutaneous core biopsy, usually ultrasound guided, is probably preferred. Let's move on to the next question. Yeah, natural history of disease. You got that right as well. I think you can just talk about the different routes of spread. Did you go through that? So do you want to maybe explain the different routes of spread and where it would spread to?
Okay, so I suppose as with all gastrointestinal malignancies, they can spread to the liver hematogenously. And I'm guessing it can spread lymphatically somewhere as well, maybe the lungs, because eventually all lymph empties back into the lungs.
Yep.
And then you can spread, or because the pancreas also doesn't have a nice capsule, it spreads to nearby structures as well.
Yeah.
So like the spleen, duodenum, I don't know what else is
nearby,
nearby,
nice.
stomach. Yeah.
Nice, yeah. So it can spread to, when I think nearby structures, I guess the way I think about this is if it's going to spread to nearby structures, it'll go left and right, so to the liver and the spleen. If it's going to spread via the hematogenous, so blood, it's going to go vertically up. So it's going to go to the lungs, the pleura. It can also go to the liver. It can go to the bone. So lungs, liver, pleura, bone. So it goes up. And then you should know the nodes which a pancreatic malignancy would spread to. So what is the arterial supply of the pancreas? This will help you with the nodes.
Okay, so the arterial supply, it's a foregut structure. So branches, is that a foregut structure? Yeah, I think it's a foregut structure. So celiac trunk, it has branches from the splenic artery, like pancreatic branches from the splenic artery. And then there's also like those pancreatic or duodenal arteries from the gastroduodenal artery.
Yep, so that's from the celiac trunk, but there's also the inferior pancreatic or duodenal artery, which is off the SMA. So it's a similar supply via the lymph nodes. So lymphatic drainage is via the pancreatic or duodenal nodes, and that will eventually move up into the pyloric nodes. So I think it's the prepyloric nodes, and that'll eventually go into the nodes that are associated with the celiac trunk and the superior mesenteric artery. So you can say the celiac nodes and the superior mesenteric nodes. So that's the lymphatic drainage of the pancreas. So that would be important to mention. And yeah, I guess the way I think about the different subtypes of pancreatic malignancies is how you broke it down, exocrine and endocrine. The only thing is with the actual exocrine, you could briefly explain that, we can have ductal adenocarcinomas, which make up 85% of malignancies. And you can talk about how that arises. You can say there is some sort of metaplasia in the ductal epithelium, and this can be due to oncogenic mutations in KRAS, P53, and that results in dysplasia and progression to a pancreatic adenocarcinoma. So maybe just briefly mention that. And then you can mention that there can also be a malignancy not just of the ductal epithelial cells, but also the mucinous epithelial cells. And that causes what we call an IPMN. That's how I remember it. An intraepithelial papillary mucinous neoplasm. It's a fat word, but IPMN kind of helps me with that. So intraepithelial papillary mucinous neoplasm. So that's a neoplasia of the mucinous epithelium of the pancreas. And then you can have...
is that different to ductal epithelium?
Yeah, I think you secrete more mucus histopathologically. I don't know much else, but that'd be the main difference. There's also like tuboepithelial malignancies, and there's also acinar cell malignancies.
Acinar cell.
Yeah. Acinar cell is pretty important because what is an acinus? You remember this from the lung?
Yeah, from the lung.
Yeah.
I mean, I just know the acinosol is where the enzymes are located.
Yeah, so acin is a functional unit of something. That's what acinus means, right? So the acina cancers of the pancreas have lipases and proteases. So they can actually present with subcutaneous fat necrosis. Or they can have proteases or elastases which damage joints, and that can cause an arthropathy. So that's how they can present. And then you mentioned the whole endocrine malignancy. So you said your whole glucagonomas, insulinomas, VIPomas. Do you know how VIPomas would present?
Yeah. What does VIP stand for?
Vasoactive intestinal peptide.
I have no idea.
It just causes increased motility. So you can get like diarrhea and stuff. Yeah. Don't know the other stuff, but yeah, why does it have such a poor prognosis? I guess have a structure to this answer. You mentioned the key point was that it's retroperitoneal, so there's poor staging. There's poor screening systems. You also mentioned that it usually doesn't cause symptoms, but one of the other reasons is it also spreads early, right? So it metastasizes very early on in the disease. So that would be the third thing you'd want to mention. It's a small thing, but just perfecting your answer. You nailed that station, but yeah. Yeah, so I guess the main reasons are that pancreatic cancers, unless they occur at the head, will often not cause many symptoms because they must grow significantly in size before they compress adjacent structures such as the spleen or potentially the liver or associated blood vessels. However, pancreatic head malignancies can compress the bile duct and cause an obstructive jaundice. Right? Why do we get... What's Trousseau's sign in... pancreatic cancer.
That's the migratory thrombophlebitis.
Yep. Why do we get that?
So you get inflammation and induration of the blood vessels. I think that's because it's some sort of paraneoplastic effect where you get release of some sort of substance.
Yeah, I think you release platelet aggregating factors that causes abnormal coagulation cascade in the vessels, and that could cause inflammation, and it can migrate around because the factor moves around the blood. So migratory thrombophlebitis. I think that's pretty sure that's almost, is it pathognomonic of pancreatic malignancy?
Surely, I think so. Isn't that how the dude found out that he has pancreatic cancer?
Yeah, I literally searched migratory thrombophlebitis and it says pancreatic cancer is the next word. Strong association with adenocarcinoma of the pancreas. So you straight away think malignancy, so that's pretty important. But good. So what were the three reasons?
What were the 3 reasons?
You tell me.
Oh,
Give it a go.
So you said that it's retroperitoneal and particularly non-head pancreatic cancers of body tail, they have to grow large in size before they compress nearby structures. Then you said that it metastasizes early in the disease course, and it has no symptoms, or is that part of the first?
That's part of the fact that it has to grow large before it compresses other structures.
Oh, and then there's no
screening.
screening.
Yeah, so the whole retroperitoneal can be part of your screening thing, but I think you can mention the malignancy has to grow significantly before it causes symptoms, unless it's a head pancreatic malignancy, which is, I'm not sure what the percentage is. And then you can mention second reason is it's retroperitoneal, it's a deep structure, difficult to obtain screening regarding it. And the third reason is it metastasizes very early on in disease. That's it. Nice. All right, what's your second case you got for me?
Not gonna lie, I didn't really go through this properly.
Do you want to do 20 more minutes then and go through that case and
yeah, we could, or we could just, if you want, we could go through it together. Up to you.
How about we'll do 20 minutes. I'll go through one more case and you finish this, you master this case, and then we'll go through this one. All right.
Sounds good.
Yeah, I'm gonna mute myself, so don't mute me because I unmuted and you couldn't hear me.
Oh, okay.
Yeah, I'll mute myself.
I'll just put a timer.
Yeah, just put a 20-minute timer.
Yeah. Alright. See you soon.
Alright. Let's go. Alright, so biomed, endocrine, and it was diagnostics, Graves' disease. So what occurs is that iodide will enter through the sodium co-transporter, sodium ATPase co-transporter into the follicular cell, and then it will have to be oxidized by thyroid peroxidase into iodine. And then that's going to enter the colloid through pendrin receptors. And then thyroid globulin, which is a protein in the colloid, is going to bind the iodine residues to tyrosine in its structure. And you can form monoiodotyrosine or an MIT. And you can form diiodotyrosine, which is DIT. Now, T3 is formed from one molecule of monoiodotyrosine, one iodine, plus a diiodotyrosine. So that's going to be 2 iodines. And then you can have a thyroxine, which is T4, and that's formed from 2 diiodotyrosines, which have 2 iodine molecules each. So that's 4 total. Yeah, and that's how we make our T3, T4, and then lysosomal enzymes will cleave T3, T4. Now, what does TSH have to do with this? TSH effect. All right. So we have thyroid stimulating hormones released by the anterior pituitary, and it regulates TSH release. TSH stimulates thyroid follicular cells to release thyroid hormone in the form of T3 and T4. Yep. Homology T3 comes from T4, peripheral conversion to T3. Tetraiodothyronine, also known as thyroxine, is 80%, and it is then deiodinated into T4, and then it negative feedbacks. Issues of concern. It also makes sense. What can increase? So estrogen can increase TSH, and then dopamine or somatostatin can actually negative feedback and inhibit TSH. And obviously iodine deficiency can decrease thyroid hormone. And then TSH stimulates exocytosis of thyroid T3 and T4 into circulation. So T4 makes up about 80% of your thyroid hormone, and T3, which is triiodothyronine, is about 20%, and that's your active form. And the last thing we can mention is that your T4 is deiodinated into T3, deiodination into T3 to form active hormone peripherally. And then we can talk about what its actions are. What are the actions of thyroid hormone? TSH is G protein coupled receptor, thyroid hormone mechanism. Thyroglobulin. Thyrocytes in the follicles produce thyroglobulin. Iodine uptake. Protein kinase A causes basolateral sodium iodide symporters driven by sodium potassium ATPase. TPO. Oh, so oxidation, iodination. Oh, links tyrosine residues to I2 and then a coupling. So it's involved in oxidation, iodination, and conjugation. Oh, right. There are 5 steps. Sodium iodide cotransporter driven by the sodium potassium ATPase pump. In follicle, thyroglobulin protein secreted by thyrocytes. Thyroglobulin protein secreted by thyrocytes, and thyroglobulin protein is secreted by thyrocytes, and thyroid peroxidase does 3 things. Number 1, it oxidizes iodide to iodine, and in the colloid it's going to cause iodination and then conjugation. Thyroid peroxidase causes iodination, and then it will cause conjugation. And it will cause conjugation with triiodothyroxine is formed. T3 and T4. And then finally, it's going to lysosome enzymes. Propylthiouracil is the main medication we'd be using, propylthiouracil. And what is thyroid storm? Etiology is unclear, and there's an increased T3, T4, a rapid increased response. And it could be propylthiouracil, and it can be carbimazole and propylthiouracil. So let's go through diabetic ketoacidosis. That'll be my next case. So let's see what BMJ has for ketoacidosis. A 24-year-old male presents to ED with weakness and lethargy. He's complaining of thirst and vague abdominal pains. He's not been eating. He's vomited repeatedly over the past 2 days. Examination reveals a pale, thin, and drowsy man with dry mucosae and ketotic fever. Urinalysis shows glucose and ketones, which are provisional and differential diagnoses. My provisional diagnosis, given the presence of weak abdominal pains, ketotic fetor, and evidence of wasting in a young male, is concerning of diabetic ketoacidosis. I'd like to include other causes of increased urinary glucose, and this could include type 2 diabetes mellitus, hyperglycemic hyperosmolar state, and other differentials of vague abdominal pains in a 24-year-old may include life-threatening causes such as appendicitis. I might like to exclude bowel obstruction, potentially gastroenteritis, lower MI. However, this doesn't fit the more chronic picture that we're observing, subacute picture that we're observing, and bowel obstruction would be another life-threatening differential I'd like to exclude. So in the pathophysiology of diabetic ketoacidosis. Diabetic ketoacidosis results from a failure of the, so what, I need to actually go through this. My teacher, aren't we? There's polydipsia, there's glycosylketonuria, and its first presentation type 1 diabetes mellitus. Other causes of ketosis could be starvation ketosis. Other causes could include a lactic acidosis, uremic acidosis, so chronic renal infections. Ethylene glycol ingestion can present this way, and alcoholic ketoacidosis. So there might be a starvation or alcoholic ketoacidosis, uremic, non-ketotic hyperosmolar hypoglycemic state, dehydration and salicylate poisoning. Sure. Pathophysiology due to lactic acidosis, starvation, alcohol, salicylate, hyperosmolar hypoglycemic state. DKA. Insulin deficiency. So it's due to insulin deficiency, and there's an increase in the counter-regulatory hormones. So relatively glucagon increases, and there's also catecholamines that increase, cortisol that increases in the growth hormones. So increase in glucagon will promote the conversion of, will initiate the process of lipolysis, and the free fatty acids can be converted into ketones. So there is at least glucagon, catecholamines, cortisol. This results in increased ketones, urine, and a metabolic acidosis. And these hormones abnormalities lead to glycogenolysis, and the free glucose can be used to increase glucose and osmotic diuresis. and that can also lead to electrolyte loss, and that can cause a pseudohyponatremia, lead to deosmotic diuresis, and there's water loss and electrolyte loss, so water can shift to the extracellular space, and that can cause a pseudohyponatremia. There may be electrolyte imbalances such as sodium loss and water shifting to follow this osmotic gradient, leading to a dilution of pseudohyponatremia, and here is increased hydrogen, so increased activation of the hydrogen-potassium exchanger in cells. So hydrogen moves in, potassium can move out, so that can result in potassium depletion. With increased lipolysis, they normally converted to triglycerides. However, in the presence of glucagon, the liver increases ketone body formation, and keto acids are neutralized by bicarbonates. So bicarbonate stores are depleted, leading to beta hydroxybutyrate and oxaloacetate are the main ketones formed, and lactic acid is also produced. So what is the pathophysiology of diabetic ketoacidosis? Its hallmark is caused by a decrease in your insulin production by the pancreatic cells, as there is an autoimmune condition and destruction of the beta cells, relatively as a counter-excess of glucagon production. The counter-excess of glucagon production favors the process of lipolysis. However, due to the increase in glucagon levels, the free fatty acids will move down the ketone synthesis pathway, in which we produce your ketones beta hydroxybutyrate and oxaloacetate. As a result, this causes an acidosis, as these acids can decrease your bicarbonate levels in your blood and decrease your pH. Additionally, there is electrolyte imbalances. As sodium is removed, water will follow. It causes a pseudohyponatremia. Also, since there's increased hydrogen, the hydrogen will exchange with the potassium in the intracellularly, and thus you'll get depletion of potassium stores, but you'll also get a hyperkalemia. Right, why do you see polyuria? It'd be osmotic, right? There is increased glucose that's lost in the urine, and osmotically water is followed. And why is it polydipsia? And that's due to dehydration. What activates thirst? H&G-CoA synthase. Produces more acetyl-CoA molecules, so as there's more lipolysis, produce more acetyl-CoA molecules that can move down H&G-CoA synthase and produce acetoacetate and beta hydroxybutyrate. And there's H&G-CoA synthase. The three hallmarks of diabetic ketoacidosis are hyperglycemia, ketosis, and metabolic acidosis. That's the subsequence of ketosis. What are symptoms and signs? Polyuria, polydipsia, abdominal pain, nausea, vomiting, Kussmaul breathing. So the Kussmaul breathing is an increased respiratory rate observed in metabolic acidosis. Kussmaul breathing. cause mild breathing, and there is ketotic breath, there is drowsiness and coma. What investigations would I perform? VBG is so important. Blood sugar, hyperglycemia, urinalysis in the older and DKA. And symptoms can evolve over days to weeks. Mental obtundation and coma are more frequent. Serum glucose is greater than 33.3 moles per liter. And serum osmolality is usually 320 moles per liter. Urine ketones is only mildly. Urine serum ketones are total chloride. It's usually greater than 7.3. Yeah, so ABG. So what would be the differentiating investigations? The serum glucose will not increase as sufficiently, so there'll be increase in 33.3 moles per liter. Glucose, 320 osmolality. And what causes ketoacidosis? EUCs, ABG, urinalysis, ECG, as there's increased potassium extracellularly. You do plasma osmolality, HbA1c, CMP, says dehydration, TROPS, as a stressor could be MI, chest X-ray, CT brain. Right, so what precipitates ketoacidosis? Non-insulin compliance, exercise, infection, infarction. Exercise, infection, infarction. So any stressor could be a poor dietary control of insulin, exercising, infection, vascular events, and certain medications as well. Taking cocaine. ABG, this is clearly a acidosis. It is a metabolic acidosis with a base deficit, and this can indicate there is an anion gap. The base X is negative 15, so the anion gap metabolic acidosis. So I'm concerned about other effects, other causes, and this could be due to alcohol ketoacidosis, starvation ketoacidosis, salicylates. It can be due to the actual diabetic ketoacidosis. Anything else that I can think of? Clinical chemistry. Urea is going to be high. Bicarb would be low. Everything else would be high. ABG. Why is there respiratory compensation? Cause mild breathing, high respiratory rate with deep breathing. How do you calculate an anion gap? It's sodium minus chloride plus bicarb. Should be isn't it sodium plus potassium? Yeah, sodium plus potassium minus chloride and bicarb. And it's seen in oh, that's such a good mnemonic. An anion gap is ketosis, uremia, starvation, Kurzmal, ketosis, urea, starvation, methanol, alcohol, lactic. I forgot lactic acidosis, that's an anion gap. So ketosis, uremia, starvation, methanol, ketosis, uremia, starvation, methanol, alcohol, lactic. Ketosis, uremia, starvation, methanol, alcohol, lactate. Ketosis, uremia, starvation, methanol, alcohol, lactate. And a normal anion gap metabolic acidosis is seen in renal tubular acidosis, medications, saline infusion, hyperaugmentation. What is hyperaugmentation? What does that even mean? Intravenous supply of nutrients. Addison's disease, where there's inadequate ADH. Tubular acidosis, drugs, diarrhea, loss of bicarb. So fluid replacement is very important, and you'd give 0.9% sodium chloride. You'd give bolus 2 to 3 liters over 1 to 3 hours, and then you give insulin, as there is a risk of decreased potassium. the person has decreased potassium stores. So if you give them insulin straight away, it can drive potassium into cells. So there's also low potassium. So you can give short-acting insulin the first hour, and then glucose should fall by, and then it can cause hypoglycemia. And then when normal, you add dextrose as well, and you monitor fluid output and input, mental status, respiration, and bicarb. Alright, I'm ready. My man, are we ready? Next case. Mr. Abid.
Yes, sure.
Are we ready? I went through one more case for you. You got...
Hey, you're so speedy.
Huh?
You're pretty speedy with these cases.
Yeah, man, I got a speed for you. 20 minutes per case.
Alright. You gonna go first?
Yeah. I don't mind. Scissors, paper, rock.
Alright. That's right.
Scissors, paper,
rock.
Alright, I'll go first.
Alright.
What's the case?
Endocrine path.
Oh, look at this, man. Give me my weaknesses. Hypothyroidism, right?
My weakness as well, yeah.
Alright, let me just turn off the music and let's get into it. Okay. You mind if I quickly use the restroom? I'll be back in like a minute. I'm just gonna need to get my brain ready for this case before I get my backside whooped.
Yeah. Crapping his pants. Hypothyroidism, yeah, no worries.
I'll be back in 1 sec.
Okay.
Alright, I'm ready. For a Sunday night session, I have too much energy at midnight. Let's go.
Yo, alright.
Alright, you got your timer ready?
One second.
Also, what I'm thinking is,
Yep.
for future cases, how about if there's no like data which I need to read, how about we don't tell each other the case and we just ask the question? Because that'll mimic like the actual biomed stations where you don't know what the diagnosis is. Right? Do you know what I'm saying? Like I straight away know this is hypothyroidism, but if I give you a case without telling you the name of the case, it would like actually get you to proper think about it and see whether you'll actually follow the same pathway of thinking. So we can kind of mimic that.
I reckon we'll try that next time, yeah.
Yeah. We'll try it for your case. A bit late for mine. Alright, let's go. Yeah, start the timer.
Okay.
Yep, I'm ready for questions.
Okay, so what's your diagnosis?
Given the presence of a diffusely enlarged thyroid gland alongside symptoms of hypothyroidism, including fatigue, menorrhagia, and weight gain, I'm concerned about causes of hypothyroidism, and this can include the chronic phase of Hashimoto's thyroiditis. I'd like to also exclude subacute or postpartum. I'd like to exclude Raydel's thyroiditis as another cause of hypothyroidism, and other causes of hypothyroidism could include decreased iodine consumption. It could be adenoma, and I'd also like to exclude malignancy given that we have an enlarged thyroid gland. And then congenital lesions such as thyroglossal cysts, potentially branchial cleft cysts would also be on my differentials. And I might like to also exclude causes of jaundice, such as hepatic disease, hemolytic conditions, post-hepatic causes, and other causes of fatigue, which could include hypoglycemia.
Oh, nice. Okay. What investigations would you perform?
Okay. Given that there is an enlarged thyroid gland, the diagnostic investigation may be that of a biopsy with histopathological analysis, and this may be done via a fine needle aspirate to assess the cells present and exclude malignancy. However, we might begin with bedside investigations followed by laboratory and imaging, and bedside investigations could include I might like to do SpO2 given the patient is fatigued to look for any evidence of decreased oxygenation, and then full blood count to look for any evidence of anemia given the presence of fatigue. And I would then like to do EUCs, LFTs. And then I might like to do thyroid function tests to assess the actual presence of hypothyroidism T3, T4, specifically looking at the TSH level, which would be the most sensitive. And then I might like to do a B12 and folate to exclude other causes of anemia given the presence of fatigue. Blood glucose or HbA1c may also be done. And then I'd proceed to imaging. So I could do an ultrasound of the thyroid followed by a biopsy as mentioned.
Nice. In your differentials, you mentioned Hashimoto's thyroiditis. Are there anything in the bloods that you can find?
I could look for antibodies to thyroid peroxidase. So I could look for thyroid peroxidase anti-immunoglobulins in the serum potentially to look for Hashimoto's thyroiditis.
Okay. What's the management of hypothyroidism?
The management of hypothyroidism can be broken down into pharmacological and non-pharmacological management. Non-pharmacologically, we could improve the patient's diet. So this could involve the consumption of more iodine-rich foods or iodinated salts. And then it could also be pharmacological management. So this could involve supplementation with thyroid supplements.
Yeah, sure. Could you give me an example of a name?
Not sure.
Okay. What's T4?
T4 is thyroxine, so we could give thyroxine supplementation for the patient.
Yeah, nice, very good. What's the clinical manifestations of hypothyroidism?
Yep. So hypothyroidism is due to a decrease in triiodothyronine and thyroxine in circulation, and this results in decreased activation of the sympathetic nervous system as there is a decreased expression of your sympathetic adrenergic receptors, and this may result in cardiac symptoms such as bradycardia, and may also result in decreased contractility of the heart, which may lead to cooler peripheries. There may be decreased activation of the sodium potassium ATPase channels, which can result in decreased thermogenesis. So that can also lead to patients feeling quite cold and overall the patients might appear to be quite slow in their manner, and we may also observe loss of the outer 1/3 of the eyebrows, weight gain, which could be another symptom of hypothyroidism due to decreased activation of your entire metabolic rate, and yeah.
What is sick euthyroid syndrome?
Sick euthyroid syndrome could refer to clinical manifestations of so there would be normal T3 and T4 levels. However, the patient would have clinical signs of either hypo or hyperthyroidism, and this could be due to increased response to the existing T3, T4 receptors, or there could be a transient increase from a hypothyroid state to euthyroid state, and the increase in T3, T4 may cause symptoms.
Okay. So the patient returns 10 years later for evaluation of profound fatigue. Examination is significant for periorbital edema, blunted deep tendons showed reduced sodium levels. What is this complication of hypothyroidism?
This appears to be a progression of hypothyroidism given the presence of bradycardia. This could be a profound hypothyroidism that's progressed, and not sure.
That's all right. And last one, could you explain the pathology behind Hashimoto's thyroiditis and subacute thyroiditis?
Yeah, so in Hashimoto's thyroiditis, there are antibodies to thyroid peroxidase. Thyroid peroxidase is involved in 3 primary steps in the thyroid tissue, including oxidation of iodide, iodination of thyroglobulin, and conjugation to form T3, T4. Thus, antibodies to these 3 processes may result in destruction of the thyroid follicular and colloid tissue. In the acute phase, cause a release of thyroid hormone, and the chronic phase, a hypothyroidism. Subacute thyroiditis may be caused due to numerous phenomena. There may be post-infection or postpartum, and it's termed subacute as due to the progression. I'm not sure, it takes days to weeks. I don't know.
I don't know either. That's good.
Let's go through it.
Like overall, that was the last question, and you're just at the time as well. Yeah, you did pretty well, man.
No, what the hell is the whole 10 years later thing?
Oh, yeah. That's it's like, you see how in hyperthyroidism we had the thyroid storm, which is the acute medical emergency?
Yeah.
This is the myxedema coma.
Oh.
You remember that? Myxedema coma, yeah.
Shit.
We sort of went through
myxedema
that. Very briefly, yeah.
So thyroid storm, and this is the other end where it's myxedema coma. I was about to say status thyroiditis or something, but yeah, myxedema coma.
Mate.
Myxedema coma. Wait, forget that. That's what I missed. Myxedema coma. Shit. Okay. All right. Let's go through the questions.
All right. Well, let's just start from the top then. With diagnosis, very good. You mentioned, that this is hypothyroidism, and you straight away talked about Hashimoto's, which is like the most common cause in iodine sufficient countries like Australia. I thought like the way that they've broken it down, I think it's much more elegant than the hypothyroidism case, where they talk about primary hypothyroidism, and then there's various subcategories like you said, the iodine deficiency, the thyroiditis, right, subacute, all that, as well as like medications, so or iatrogenic as well, like surgeries after administering radioactive iodine. They can all cause primary hypothyroidism, and then you just go up that axis, the hypothalamus pituitary thyroid axis.
Yeah.
And they are like secondary causes and tertiary causes.
Okay. Can I give that? I'll give that a quick go. Let's see. All right. So if I were to re-answer that question, cause of hypothyroidism. Hypothyroidism is most commonly caused by Hashimoto's thyroiditis, which is due to lymphoid infiltration and fibrosis of the thyroid gland, and resulting in acute hyperthyroidism followed by a hypothyroidism due to the release and destruction of thyroid tissue. Other causes of hypothyroidism could include the burnt out phase of Graves' disease. There may also be subacute thyroiditis, such as Raydel's thyroiditis. I'd like to also exclude dietary causes, such as iodine deficiency. Certain medications can cause this, including amiodarone. There could be infiltration of, for example, amyloid. So amyloidosis can cause a hypothyroidism. There can be surgical removal of the thyroid tissue, and I'm also concerned about pituitary causes or hypothalamic causes of decreased TSH, thyrotropin-releasing hormone, and there's also Refetov syndrome where there is decreased there's increased resistance of peripheral tissue to T3 and T4.
Perfect.
All right, next.
All right. Investigations, like the only other thing would be with the antibodies.
Yep.
Not only can you get thyroid peroxidase, but you can also get thyroid globulin antibodies.
Anti-thyroid peroxidase,
and there's an anti-nuclear factor antibody, which I'm not sure what that does, but definitely the first two would be important.
Okay, right. So my errors so far is I didn't have a structure for hypothyroidism, and I didn't talk about the antibodies in the tests. Is there anything else?
No, pretty much covered everything else. You didn't miss it.
Alright.
So management. The management is literally just one drug, levothyroxine, which is T4.
Treatment.
So it's not just thyroxine, just add the lever in front of it.
Okay. Yeah. Okay.
Yeah.
Right.
And like you can get T3 as a medication, but they don't really usually give T3 because T4 gets converted to T3 anyway, and I think the T3, because it's more potent, there's more side effects.
Yep, that makes sense.
T4 is given.
B12, folate, and yep. Cool. Next.
Yeah. And the clinical manifestations, I think you did really well with that. If you wanted more structure, you can, like the table they've given there, just go by body systems.
That makes sense. So you have dyspnea, respiratory, GIT, you can get constipation, I didn't mention, CNS, sluggishness. I didn't mention decreased reflexes. So manifestations, break it by system. I missed constipation, slowed reflexes. Is it mental fog that it causes?
Yeah, mental sluggishness.
And dysmenorrhagia as well.
Yeah.
Does it cause what was the whole orbit problem that happened in myxedema coma?
Yeah, so you see how we talked about the fibroblasts getting activated in Graves?
Yeah.
So like normally the myxedema, which is just deposition of that connective tissue glycosaminoglycans, it's a feature of hypothyroidism, but it's throughout the entire body, right? For Graves is special because we know that it causes hypothyroidism and very localized myxedema deposition.
Yeah.
So like behind the eyes and in front of the tibia.
Yeah.
But like it's mostly a feature of hypothyroidism.
Oh really?
Yeah. Yeah.
Why is that? Wait, I didn't get the whole systemic part.
Yeah, I don't know why it's like I understand the like Graves' disease one, fibroblasts getting activated. I'm not really sure with hypo.
Okay. And what else does it say for myxedema coma? Medical emergency, and there's some kind of stressor, and it further decreases metabolic rate, oxygen consumption, and you get mental state changes. You get again hemodynamic instability. Do you know why we get decreased sodium?
we get decreased sodium?
Yeah.
Let's try to think.
Because that's like in the stem.
Is it?
Yeah, it says if laboratory investigations show reduced sodium, so it must be important.
It's probably due to decreased aldosterone and like in relation to a decrease in sympathetic nervous system activation.
It says there's elevated levels of ADH. There's decreased renal perfusion, and that activates ADH and aldosterone, and that prevents you excreting water, so you get a hyponatremia. But why do you get decreased blood? Oh, you get decreased blood flow because of decreased cardiac output, right? Decreased contractility of the heart, decreased perfusion to the kidneys, and that's going to result in increased activation of aldosterone, and vasodilation of vasculature will also result in the release of ADH. Does that make sense? Let me just write that down. So we get decreased cardiac output, which is going to decrease renal perfusion. And that's going to release aldosterone. And that's going to cause water retention. And also vasodilation results in decreased blood pressure, and you get activation of ADH. And that causes a dilutional hyponatremia. Yep, alright, next.
Awesome, alright. Then it was explaining the pathophysiology or the pathology of Hashimoto's thyroiditis and subacute thyroiditis. I think you did a pretty good job with that. The only thing was with Hashimoto's, I'm not sure if you mentioned the lymphocytic infiltrator.
No, I didn't. No, I didn't mention it, yeah,
So yeah, but you did mention the antibodies, which was good. And so you get destruction, and because you're getting destruction, that's why initially you can get hypothyroidism, because you have release of the T3 and T4. And later, you get atrophy of the thyroid follicles and the colloid. And that's why you get hypothyroidism.
Yep.
And then the subacute thyroiditis, like there's two types that they've mentioned in the notes. They've mentioned the decor-vein and the postpartum. And the decor-vein is the painful one that often follows an infection.
Yep, viral OT, Coxsackie mumps, adenovirus, yep.
And then the other one is painless, like the postpartum.
Painless thyroiditis. Your silent thyroiditis is your painless, and it's like postpartum, autoimmune. And Raydell's, is Raydell's like a type of silent, or is that its own category?
It might be its own category, but it is a cause of hypo, and it's painless as well.
Oh, right. So much. So Dequane's after OT, painful, add NSAIDs and prednisolone, and then your silent could be postpartum, autoimmune, and I'll just remember decor-veins, and then, okay, nice.
Nice.
Is that everything?
The final thing was the sick euthyroid syndrome.
Oh yeah, what was that?
Yeah, so basically it's kind of like, you see how I think last time we were talking about you see how the name, like you can get cholecystitis without any stones. Do you remember that?
Yeah.
And that's like in critically ill patients.
Yep.
This is sort of similar to that. This is where you get symptoms of you get low T3, T4, and TSH in a critically ill patient.
Low T3, T4, and TSH.
Yeah.
Then why is it called euthyroid if there's low T?
I think it's called euthyroid because the patient won't have symptoms of hypothyroidism. If that makes sense.
So there is changes in T3, T4. But it says there's changes in T3, T4 without thyroid pathology.
Yeah, it's to do with the cytokines and...
Cytokines that results in peripheral deiodination clearance. And
so the patient's like clinically euthyroid, but they're biochemically hypothyroid. So it's sort of like just abnormal findings on TFTs.
Right. Okay, that makes much more sense. So it's typically abnormal findings on TFTs, and that's characterized by increased cytokines, which can impair deiodination of thyroid hormone peripherally, and that can cause decreased T3. That can also decrease TSH, and if it progresses, it can be lower T4 as well, right?
Yeah.
Okay.
Easy.
So it's just it's a laboratory finding.
Yeah.
Finding in an otherwise well patient.
Oh no, like as in they're unwell.
Yeah.
Right.
That's why they have the cytokine release. Yeah.
Yeah.
Okay. So any other condition that releases cytokines. Nice. Are you ready for your case?
Yeah, let's go.
Laboratory finding in a sick patient. Are you going hospital tomorrow, by the way?
No, bro.
Yeah, same. Seems. I gotta do
Public holiday.
some revision.
Gotta take advantage of that.
Yeah. That.
Did you find out what you're doing next week?
Trauma. Yeah,
Nice.
so my elective. I'm just pretty much doing my elective again.
Yeah. Elective for a week.
Yeah.
Are you doing it for a week or 2 weeks?
1 week.
Okay.
Yeah, so hopefully I get a good... Apparently the doctor's really good. Dr. Langcake. There's deiodination of thyroid hormone. So you get low T3, low TSH, low T4. Alright. When you're ready, I'll start a timer.
No worries. Am I gonna... So are you just gonna read the case out?
Yes, my friend.
Alright.
Actually, I'm not gonna read the case out to you. I'm gonna copy paste the stem without the anything else.
Okay. Are you gonna message it to me or something?
Yeah, on Facebook. So the second I message it to you, timer's gonna start.
Sheesh.
Are you ready?
High pressure. Yeah, let me just open it up.
My internet's just loading. But I'll send this right here. There you go.
Oh, it's tiny, mate. Okay.
Timer started.
Sheesh, alright. Okay, I'll give it a go. Alright.
So what is your provisional differential?
Yeah. So my provisional diagnosis in this case is diabetic ketoacidosis. Given the young age of the patient, with symptoms of hyperglycemia and ketones present in the urine. My differentials for this case include other causes of ketoacidosis, such as starvation-induced ketoacidosis, particularly because this patient hasn't been eating over the past 2 days, as well as alcohol-induced ketoacidosis. And then they can, on the other side of the spectrum of DKA, the patient might have HHS or somewhere in between that spectrum. And then other potential differentials include diabetes insipidus, where patients, and that might explain the polyuria.
Okay,
I'm not sure if this patient
good.
has it, but yeah.
And what's the pathophysiology of diabetic ketoacidosis?
Yeah. So diabetic ketoacidosis, primarily occurs in type 1 diabetics who have a an absolute insulin deficiency, and that causes the counter-regulatory hormones such as glucagon and catecholamines to increase, and they then exert various metabolic functions such as increasing glucose in the blood by breaking down glucagon, and also generating glucose in the liver, so gluconeogenesis, glycogenolysis, and then they also induce lipolysis, and each of these sort of non-carbohydrate molecules can be used by the liver to produce ketones as an alternative energy source, since there's no insulin and that is not being taken up by cells.
Good. You mentioned something about the breakdown of glucagon. Do you want to revise any part of that statement?
Say that again.
You mentioned there was a breakdown of glucagon.
Sorry. I mean, glycogen.
Okay.
Yeah, breakdown of glycogen.
And why do we see polyuria and polydipsia?
So that's to do with the hyperglycemia, or the elevated glucose levels in the blood. Essentially, it acts as an osmotic agent, draws water in from cells, and then when this goes to the kidneys, it filters freely through the glomerular filtration barrier, and then it reaches the threshold of reabsorption, and it causes the patient to diurese, so increase the urine production. And because they're losing a lot of water, they become thirsty, essentially due to ADH and things like that.
Good. And what investigations did you perform?
Okay, so at the bedside, investigation will break it down into bedside bloods and imaging. I think the diagnostics is clinical, in addition with positive ketones. But then at the bedside, we can do urinalysis, as well as particularly looking for urinary ketones and glucose in the urine. For bloods, we can do full blood count to see if there's an infection or anything that might be triggering the DKA. EUCs are important to determine the patient's electrolyte status, since they're losing a lot of urine, and they might be vomiting. And we could also do serum ketones and serum osmolarity. And then I don't think any imaging is required.
Okay. And how would you know if the patient is in a metabolic acidosis or not? Is there any investigation you might like to add for that?
So you could do a VBG. And that would give you the acid base status.
Yeah. Is there anything else you're looking for in the VBG?
Anything else? I mean, you're looking at the anion gap. I think that's what you're after.
Okay, and I've sent across the blood gas results. So could you interpret this?
Oh, have you? Okay. So, looking at the ABG, the patient has a metabolic acidosis that is uncompensated, and we can use the clinical chemistry to determine if it's a high anion gap or a normal anion gap. If I remember correctly, the way you do that is sodium minus the bicarb plus the chloride, and that has to be greater than, I think, 8 to 12 something. So this one, I think this is a high anion gap metabolic acidosis that's uncompensated.
Okay. Good. Okay. And what precipitates diabetic ketoacidosis?
I think there's various triggers that can precipitate DKA. one of these could include, non-compliance with insulin therapy. It could be a first presentation in a younger patient. And then other things like trauma, infection, anything that increases stress and the body's demand for insulin.
Good. And what are the principles of managing this patient?
Okay, so principles of management include management. We can have sort of supportive and specific treatment. Supportive treatment would include the administration of fluids, since they're losing, and electrolytes, since they're losing a lot of that. And then the specific treatment would include the provision of insulin, so that you can, because they have an insulin deficiency, so that you can correct the hyperglycemia. And then you also want to keep an eye out for potassium, because that can be elevated. And
why would potassium be elevated?
I think potassium is elevated because it's sort of part of the body's response to the metabolic acidosis. We have increased activity of the hydrogen potassium exchanges, and so in an attempt to decrease the acidosis, the hydrogen ions get shuttled into cells. The potassium gets shuttled from within the sort of intracellularly to the serum, to the bloodstream.
Okay, and what's the basis of Kussmaul breathing? Why does that happen?
Yeah, so that Kussmaul breathing is the deep, labored respiration that occurs in DKA, and the reason for that is to do with the body's compensation, or the attempt to compensate for the metabolic acidosis. And so, if you can increase the respiratory rate and the tidal volume, then you can blow off more CO2, and therefore you can decrease the acidity of the blood.
Nice, you smashed it. That was a really good case. You smashed that up. Nice.
I'm not sure about the management, bro. Management was tough.
No, I think you got the key points. And we'll talk about the management now as well. Right, so I guess your provisional and differentials were good. You mentioned other causes of polyuria. I think you should also exclude other causes of vague abdominal pain in a 24-year-old, right? Could be appendicitis, potentially. You don't know whether he's got fever or not, but I think you could also just talk about other causes of abdominal pain. Otherwise, what are the other causes of ketosis?
All I know is starvation and alcohol.
Yeah, alcohol and starvation would be the main two ones you mentioned. And we'll talk about the whole Anion Gap metabolic acidosis causes when we get there. So that was good. Yeah. Pathophys, yeah, you broke that down very well. I think just stress the whole acidosis. That'd be a very important thing to stress. You stress the hyperglycemia and you stress the ketone synthesis, but the third part of this triad is the acidosis. So it'd be important to mention that the three primary changes that occur in diabetic ketoacidosis is hyperglycemia, ketosis, and a metabolic acidosis. And then you can break down each one, right? Why is there ketosis? You could mention, the whole, there's a relative excess of glucagon. When glucagon is present, what that's going to do is you result in lipolysis, production of free fatty acids, and that's also increased by catecholamines. But at the same time, the free fatty acids produce acetyl-CoA, and it's acetyl-CoA that goes down the whole cholesterol synthesis pathway. If you remember, there's HMG-CoA synthase, and that eventually will produce your ketones. Do you know what the two main ketones are? Ketoacidosis?
Let me think. I think beta hydroxybutyrate.
Yep.
Something like that. And then acetone is the thing that gives you the fruity breath.
Yep. And oxaloacetate is the other one. But yeah, I believe oxaloacetate breaks into acetone. But yeah, good, nice.
Okay.
And next point, yeah, make sure for your investigations you mention VBG. That's like almost compulsory to do for every single patient with ketoacidosis. So in ED, they kind of treat it like a bedside test, right? It's up to you. Are you going to think of it like a bedside test or add it?
I don't know.
For me, I always forget VBGs, so I like to put it in bedside so I don't forget it.
Okay, fair enough.
But yeah, I don't know, whatever works. Yeah, so did you mention HbA1c for investigations?
Oh, no, that's important.
That would be important too. For EUCs, you can mention what characteristic electrolyte changes you would observe. Any idea why you'd see hyponatremia?
Hyponatremia. I don't know. Are you losing sodium in the urine as well?
I think so. You reduce sodium in the urine, and there should be you're going to get activation of ADH and some water, but the net thing is going to be a water loss. Yeah, I think you're right. You might be losing sodium. I'm not too sure. Let me let's have a look at the answers and see if there's anything about that. Nope. 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 Oh yeah, it's pseudo hyponatremia due to hyperglycemia. Why does that happen? Hypernatremia. So the reason we get hyperkalemia is there's actually almost twofold. The main reason is what you mentioned, which is that we have the whole activation of the sodium hydrogen exchanger, right? So since you're in a metabolic acidosis state, that's going to result in hydrogen in the extracellular space being exchanged for intracellular potassium. So what actually happens is you deplete potassium. You actually have low potassium in the body, but all of it's been shifted extracellularly. So you have a extracellular hyperkalemia. So that's why you don't, and that goes back to management, that's why you don't give them insulin in the first hour. You actually focus primarily on fluid resuscitation first. After that, and after you've corrected the fluid resus and you've enabled, the potassium to shift back into its correct space, then you can provide insulin. Otherwise, you can push all the insulin that's outside back into cells. And remember, there's a net decrease in insulin, net decrease in potassium in the body. So what's going to happen is you can cause a hypokalemia. So you want to monitor the potassium status. That's one of your principles of management in DKA. You want to constantly monitor potassium. What you'd also want to monitor is you're giving them fluids aggressively, like 3 liters in the first couple of hours. So what might you want to also monitor?
Sodium.
Yeah, sodium. Also, like urine output. So you'd want to do fluid charts for the patient as well to make sure that they're euvolemic and all. You nailed the respiratory compensation. One thing is, I thought we used the base excess to calculate the anion gap. So you know how you're saying we could put in another calculation and do sodium plus potassium minus chloride plus bicarb. You see here the base excess is -15. Doesn't that tell you that it's an anion gap metabolic acidosis? Like I had a look at this. The way I understand this is when the base excess is positive, there is an excess base. That makes sense, right? If the base excess is negative, that tells you that there is a base deficit, aka there is some additional acid in the blood that is reacting with the bicarb, which is your base, and reducing it. So that additional acid could be lactic acid, it could be acetylsalicylic acid, aspirin, it could be alcohol, it could be it could be methanol, it could be like those kinds of things. So all other causes of anion gap. So
that makes sense. So wait, so you're saying that the base is reduced, which means that the base is being used up in the because we have high acids.
Yeah, so when your base excess is high, it just means there is a lot of base, which means that that's it. It would probably be an alkalosis. If the base excess is normal, it's a non-anion gap metabolic acidosis. If the base excess is negative, that tells you that there is some additional acid that has reacted with and reduced the base to a negative value. Yeah. So that could be lactic acid, so it could be in sepsis, it could be in ketoacidosis, starvation, it could be in aspirin and all of that. So I'm pretty sure you can say here that this is a anion gap metabolic acidosis consistent with diabetic ketoacidosis. And we can see increased osmolality too. Now one question, how would you differentiate HHS from DKA?
I think with HHS you don't get ketones.
Yep.
But DKA you do.
Yep. So no urine or serum ketones. What else?
With HHS, like epidemiology-wise, it's more so in older patients with type 2 diabetes. They, have a higher BMI. I think they also have a higher osmolarity of their blood, and they have more profound volume loss.
Yeah. What about the glucose and osmolality?
So I think the glucose would be much higher.
Yeah. Do you know what the numbers are potentially?
Like 33.
Yeah, greater than 33 millimoles per liter would be the typical what you'd see for HHS. What about osmolality?
Greater than 300.
Yeah, greater than 320, 330. So you just times the glucose by 10 to get to the osmolality.
Okay.
That's how you can remember it. But yeah, that's it. Nice. You said there's going to be increased volume depletion, right? And that's because there's even more glucose in the blood, so the water's going to move out with it, right?
Yeah.
Okay. Why do DKA patients get abdominal pain?
Is that because the ketones cause contraction of smooth muscle in the abdomen?
Yeah, I think severely increased glucose can cause contraction of.
And maybe the catecholamines.
Anything else? What about severe volume loss? What can that cause to like the vessels supplying the mesentery?
Right, so like vasoconstriction of the vessels.
Yeah, you can potentially get some mild evidence of mesenteric ischemia as well. So that's like the theories as to why they get abdominal pain. It's due to the volume depletion and also due to the high glucose. Yeah, okay. Nice. All right, Master, you nailed that. You are just asking you like extra questions to just nail down everything. But yeah, that was really good. Yeah, just don't forget the VBG, and everything else was perfect. And principles of management is fluid in the first hour. After the first hour, you give them insulin. After the insulin has been, the glucose has been corrected, you give them dextrose as well.
Yeah, right.
So after the normal blood glucose, and then you monitor the potassium and the bicarb throughout because they're in acidosis, right? That's it.
Do you know how the management might differ between this and HHS? I think it's very similar. Right?
No clue. I haven't. I forgot HHS. I just quickly searched it up before I was about to teach you about what the difference is. I don't know what the treatment is. Let's have a look.
I'm pretty sure the HHS you do the same thing, but maybe I think with HHS it's just slower. Like you give 50% of the volume loss, the estimated volume loss in the first 12 hours, and then the other 50% in the next 12 to 36 hours.
No.
Because HHS takes longer to develop, and so that's why the treatment is also longer.
All right. So the fluid, the first 50% is over the first 12 hours, the next 50% is the next 12 hours. Is that right?
Yeah.
Oh,
next
nice.
12 to 36, yeah.
Nice.
It's more slower.
Yeah, it says, fluids. It's literally what you said. So give fluids, supportive care, insulin, monitor the biomarkers, vital signs, and then you give them monitor potassium. Is potassium going to be high or low in HHS, and why? This I don't know. I'm genuinely asking.
I'm not sure if it's a main, because you don't really get acidosis in HHS, right?
But yeah, in the treatment algorithm, it says like your treatment depends on whether the serum potassium is low, normal, or high.
Oh, so it could be anything.
No, they're just adding on potassium. Replacement of potassium is low, and if it's high, they just nothing, and if it's low, I don't know why potassium would be deranged.
I think it could be variable. Like you could get low potassium due to diuresis.
Yep.
But then you can also get high potassium if you have like more of an insulin deficiency, like more insulin deficiency. Because you know how it's like a spectrum, right?
Mm.
So if you fall somewhere in between, you might have increased potassium. Maybe not as much as DKA.
Right.
But I think that's why they've stratified the potassium.
Right.
Treatment based on potassium.
Nice. Do you have another case, or are we done?
Yeah, I'm pretty much done. I think I'm gonna call it a night, bro.
Yeah, probably same. We'll get some rest and we'll... That was a productive sesh, see? How
That
many
was solid,
cases did we
yeah.
do? What was that, like 6 or something? How many cases did we do?
Yeah,
1, 2,
we
3,
did
4?
heaps. I think we did do 6, didn't we?
6 cases in a day. In a damn
That's
day.
insane.
Yeah, that was good. Alright, let's get some rest. I studied from 8 to 12:40, and then now we did the Arvo sesh. This is like the most I've studied in like a day. How many hours is that? 9 to 1, that's 4 hours, right? And then 8 to 12 was... Dude, I studied like 9 hours.
Damn.
I never studied this much. I can't study more than 1 hour. I don't know how I'm doing it. It's because I'm streaming my study.
Yeah.
Which is good.
There's some good accountability.
Yeah, it is. It's really good.
Yeah.
Alright, I'm gonna head off as well, get some sleep.
Same here.
What time are you free tomorrow to do a study?
Hopefully similar time. I'll shoot you a message.
Okay. Alright, sounds good.
Yeah.
We can do a...
Alright. This is a good
we should probably finish
See
before
you later.
1. We should probably finish before 1 though, because like Tuesday we...
Yeah, if we're gonna go Tuesday.
Yeah. Alright, anyway, we'll figure something out. Catch you later, man. Good sesh.
No worries.
See ya.
See you later,
Bye.
man. Bye.
Alright, I am done. That was a good sesh. Thank you for joining. I hope you all got your work done as well. I'll message that in. Okay, I am done. I will catch you guys next session. That was a very productive session for me. And hopefully I'm not going to bomb these exams. And hopefully you all saw how I study for my exams. Teach myself. It's the best way. Alright, see you guys.